Myself to speak on subthreshold laser for diabetic macular edema. Take it. So, thank you. So, I'll be talking to you about micropulse subthreshold laser and diabetic macular edema. So, I have no financial disclosures. So, the playbook for this presentation, first of all, we'll go, why do we need an alternative therapy for diabetic macular edema at all? The unmet need, the problem, the magnitude. And how can micropulse laser subthreshold help in DME management, the rationale, which Lita has already covered. So I'll just go past that, fly past that pretty fast. And how should subthreshold micropulse laser be done in DME? Basically the parameters, and this is important. And then how effective has or is micropulse subthreshold laser in DME, the evidence to support, and where can this find a place in DME management, the future role, okay? So with that, we are in the midst of this surging pandemic of diabetes, where, it's been projected that there's going to be a 51% global increase by 2045 from the current 463 million to about 700 million. 40% of the adult population may have diabetic retinopathy, 7% of the diabetic population may have diabetic macular edema. So that's the magnitude of the problem that we are kind of looking at. So the evolution of, management of DME has moved from the erstwhile, laser photocoagulation in the 80s through the turn of millennium where we had steroids coming in, and to this current anti-VEGF era. And, evolution of DME management has moved with the anti-VEGF era, with the advent of that, from preventing visual loss, which was the case with the lasers, to currently through all these trials with anti-VEGF agents to actually gaining equity. Now, a survey of over 100,000 patients from more than 1,700 plus retina specialists showed that the comparative patient compliance for diabetic macular edema was far lesser than neovascular AMD, both US and Europe. So this is a major problem. People started recognizing this is a problem. And ASRS in its PATH survey in 2017 found that over 50%, the overwhelming majority of physicians felt that there was the need to reduce treatment burden and highlighted the need for a greater durability of therapy. Also, it was noted by healthcare authorities that there was significantly higher healthcare resource utilization in DME patients compared with non-DME patients. So this is why it is a major problem even for healthcare providers, administrators. So therefore, the unequal need of the hour was to provide therapy or offer therapy which provides maximum sustained equity gains, of course, and those that require fewer injections than the current very repetitive anti-VEGF treatments. And this would benefit patients, physicians, as well as the healthcare systems of countries. Now, refractory DME, we begin to understand present in a clear and present danger, where all the major trials showed that there was a significant quanta of patients with DME who were refractory to this anti-VEGF therapy. And why is this so? That's because simply the pathogenesis is multifactorial. Though the key driver of diabetes is hyperglycemia, and then by triggering a bunch of biochemical pathways released through different mechanisms, it triggers a number of cytokines and chemokines. Only one out of this, of course, the primary is VEGF. So when you use anti-VEGF drugs exclusively, you're addressing that one primary but only single component. There are almost half a dozen or dozen others which are not being addressed equal, kind of with the same efficacy. And therefore, through these alteration of blood-retinal barriers, increased vascularity, you do have DME. So there is, for this reason, there is some quanta of refractory DME that we have to deal with or face. Now, how can subthreshold micropulse laser help in DME management, the rationale? So with the conventional laser that we had in DME, the indications, and this was a publication we had put out from our IGO group, AIOS group in the IGO, Indian Journal of Ophthalmology, the indications, surviving indications for conventional laser, non-center involving DME, patients with recent stroke or heart attack, or those with a high cardiovascular risk, and therefore where those you might want to avoid intravitreal injections such as bevacizumab, or patients themselves decline a repetitive therapy, or as an adjunct to intravitreal anti-VEGF steroids when DME is not fully responding based on OCT. Now, ETDRS, showed us how efficacious macular photocoagulation was, but it also did recognize its limitations, such as these. And we also always, kind of recognize that there is an occasional, very rare morbidity with, continuous wave laser, accidental foveal burn, subfoveal fibrosis, central paracentral scotomas, laser-induced CNVM, rare, but could still happen. Now, comparing continuous, wave laser with micropulse, it has also done that. I'll run past this. This is continuous. That's pulse. It's in milliseconds. Micropulse is in microseconds, as the name suggests. Single pulse laser of 0.1 to 0.5 seconds, delivering a preset laser energy, whereas this is a train of multiple repetitive micropulses within an envelope. And here, in photocoagulation, you have this obvious photocoagulative necrosis of target tissue. This severe damage, whereas with micropulse laser there's a modulation of the heat shock proteins expression in the RP, and it regulates, downgrades the cytokine expression. So this is the cartoon which shows, as Lita had also shown, irreversible thermal drainage, because there's a continuous train of that photocoagulative laser, and you can see the heat quanta is massive. On the other hand, when you chop up this strain into these several micropulses, you see there's very small heat aliquots which are being raised at the tissue level, and there's enough time for it to cool. So that's basically it. Then how should micropulse laser be done in DME? So this is the guidelines which we had given. Jay had taken the lead, and this was from our group, and we had put this out. So for DME, so he's mentioned for CSCR, for DME, as we suggest, it should be 5% with the yellow laser. 577 is what we suggest. 200 milliseconds pulse duration, 150 to 200 microns, no spacing between spots, as we are reiterating again and again. Yes, please go ahead and titrate. It should be 50% of the threshold power. So how effective has it been in DME, and what is the evidence looking at backing this up? Oh, I see this. There's something wrong with the font. Anyway, subthreshold micropulse laser versus conventional. Chen gave us this meta-analysis looking at about 400 eyes who received micropulse subthreshold laser as well as conventional, and they found equity gain was significant in patients with micropulse laser compared to continuous wave at 3, 6, 9, and 12 months, and concluded that its micropulse laser was superior to conventional laser in treating DME in terms of 1-year equity gain. So there was unequivocal evidence here. Now the Diamond study by Lois et al. They also looked at this. This was a multi-center study. The previous one was a meta-analysis, and again they determined clinical effectiveness, safety, cost effectiveness of micropulse was a standard laser for DME with central retinal thickness less than 400 microns. Let me stress that, less than 400 microns. And they looked at about 266 eyes, randomized them 1:1 to 577 versus standard laser. Retreatments were allowed. Rescue treatment was allowed, anti-VEGF or steroid, if equity dropped greater or equal to 10 letters or the macular central foveal thickness increased beyond 400 microns. And they found that there was no significant difference between both groups at the end of 24 months based on equity, CMT reduction. Number of micropulse laser sessions for them were slightly greater than standard laser, and they felt that micropulse laser was almost similar and effective to standard laser, but they did add a rider that majority of patients had poorly controlled diabetes, and therefore they couldn't make a very strong comment about the efficacy. Then Wu et al. Put out this Bayesian pool meta-analysis where they looked at a number of therapies, and they concluded that the most effective therapy was ranibizumab and a continuous laser, which is greater than diode micropulse mono, greater than bevacizumab plus continuous laser, which is better than continuous laser mono. So they found the diode micropulse laser was similar to conventional laser. Now, this was very interesting. Klagi et al. Looked at what we really are kind of trying to gun for. Micropulse laser for refractory DME, the anti-VEGF combo. Where is the place of micropulse with a combination of anti-VEGF? They picked only refractory DME eyes, 42 eyes, 2 groups, bevacizumab and micropulse diode versus bevacizumab alone. And they looked at, found significant gains, CMT decrease at 3 months in patients receiving the combination. So combining micropulse with anti-VEGF therapy significantly increased the equity outcomes and reduced CMT for refractory DME. So therefore there's definitely a shot in the arm for micropulse with combination. Citric did something equally interesting. They looked at micropulse laser in DME and the impact of the central foveal thickness. So they tried to evaluate the effect of differing central foveal thickness on micropulse laser, yellow laser efficacy in DME. 80 eyes and 40 recurrent DME post ranibizumab divided into 4 groups. three of these groups received treatment. So group 1 was 200 to 300 microns, group 2 301 to 400, group 3 greater than 401. Group 4 200 to 300 microns untreated. Okay, so group 1 to 3 essentially were treated with micropulse laser and prospectively evaluated over 6 months. And they found that micropulse laser treated patients with CFT less than 300 microns had the best equity gains and CFT reduction. So there's some information for us there, and conclude that it was most effective in this subset. Now, one of our members of the Salt Society, Slavoj AIOS2025, looked at DME and biomarkers, okay, and how they affect the OCT octa parameters, and with micropulse, and they looked at all these central macular thickness, hyperreflective spots, drill, microaneurysms, macular perfusion parameters, and they found that micropulse laser reduce the number of HRS, hyperreflective spots, which are, as we know, signs of activated microglia in the retina, MA drill extension, and the area of cysts. So they suggested that perhaps micropulse laser may have an anti-inflammatory effect on DME. Now, Frizzero went further and did a systematic review and looked at the effect of micropulse laser on neuroinflammatory biomarkers, and they found that it reduced VEGF, PEDF, GFAP, glial fibrillary acidic protein, and KIR1, and increased EPO. And they also concluded that micropulse alone was safe and effective in mild DME and in combination with intravitreal anti-VEGF, especially in cases of severe or refractory DME. So this is a few experiences. This is a case where the patient has just foveal DME with a bit of intraretinal fluid. You see micropulse laser done, and then repeated again at 3 months, and then you see a good resolution at 6 parts 6 months down. This is a case with IRF plus a little bit of subretinal fluid, little bit. You can see just a very small amount. Again, micropulse done and repeated at 2 months, 6-12 improving to 6-9, and then at 5 months you see good resolution. Okay, some hard exudates were also there. A third scenario where now you have IRF, subretinal fluid, hard exudates, but it's a little thicker. You can see the fairly significant amount of subretinal fluid. So in this kind of situation, I would prefer going in for ranibizumab, reducing that SRF, then putting in micropulse laser, and you see at 4 months a good outcome. A fourth scenario where again this IRF and subretinal fluid, again fairly significant subretinal fluid with hard exudates. Here I'm doing sequential therapy, micropulse laser, and then 2 days later, just 2 days later, anti-VEGF treatment, and then at 2 months repeating the micropulse, and again you see a good outcome. So these are ways in which you can combine and micropulse, or even have it as standalone. So this was a short little study which we just concluded. One of our PGs, postgraduates, doing a thesis. We looked at studying the efficacy and safety of adding micropulse laser prior to injecting ranibizumab in patients with center involving diabetic macular edema. We looked at assessing the CMT and best corrected equity in patients receiving additional micropulse with ranibizumab versus patients receiving ranibizumab monotherapy, and compared the cumulative injections required to treat DME in each group. This was a study designed, prospective, randomized in our department over a year, and the inclusion criteria 6'9" to 3/60 patients over age 18. Quickly follow up. So basically, group 1 was the combination, group 2 was ranibizumab alone, and this was how it was. We retreated if it was persistent with ranibizumab at the first follow-up a month, and then at the second follow-up we added, if there was persistent, we added ranibizumab in that group A arm, whereas the other ones, where if it was persistent, we added anti-VEGF. We just treated with anti-VEGF only, ranibizumab. And this is what we found, that 44% were randomized to 2 treatment arms, group A the combination, group B only ranibizumab. Demographic parameters were almost all the same, and what they showed is both groups showed significant improvement in equity as well as reduction in central macular thickness from baseline to final visit. And group A, although group A had greater reduction, the combination in CMT from baseline till final visit than group B, difference was not statistically significant, though you see that the trend was a little greater in the combination arm. Whereas in patients in group A received more injections, less injections, 24 injections up to final visit. Group B, the ranibizumab monotherapy, had much more injections, and so there was a benefit in terms of reducing the number of repetitive treatments. And patients in group A, the patients with subretinal fluid, we found this was interesting, had a better resolution and improvement in equity after treatment with the combination compared to eyes with intraretinal fluid only. Again, something interesting to note. So this was the data. And finally, where can we place subthreshold micropulse laser in the management of DME? So this is just one final slide. So if anti-VEGF is contraindicated or there are compliance issues, immediately micropulse laser comes into play. Okay, that's straightforward. Non-center involving DME, again, it has significant potential. You could reduce anti-VEGF injections, so there's no controversy there again. Okay, otherwise you would treat it with focal ablative. Instead of that, you can treat with micropulse laser. Now, as we've seen in the previous studies, 300 microns was kind of a watershed. So if it is less than 300 microns or there's minimal or no subretinal fluid, as I've shown in some of the cases, you could use, and I'm not saying that you should use, I'm saying you could use standalone micropulse laser, okay, especially if there are contraindications. If there is significant subretinal fluid, we still feel that anti-VEGF would be a good idea, and then following up with a combination of micropulse subthreshold laser. If it is between 300 to 400, you could consider repetitive micropulse yellow laser, as I've shown in some cases, with or without anti-VEGF rescue. I think that's important to stress, that anti-VEGF rescue may be required, or you could use it as combination or sequential treatment. If it's more than 400 microns, perhaps it's a better idea to use anti-VEGF followed with combination micropulse laser. Thank you. Yeah, any questions?
Anand, can I ask you a question?
Oh, yeah, of course. All right.
I was wondering, like Lite was mentioning that he usually waits for 6 to 8 weeks and then repeats the laser for CSC. So in DME, if you are treating somebody primarily with subthreshold laser, how long do you wait? And is there a like, do you believe that, do you want to supplement anti-VEGF in between? How do you make the next few months planning when you're treating?
Yeah. Can I just have that slide again? I can just, illustrate that better with this thing. So, like I said, if it's less than 300 and it's showing a trend towards improvement, then I might, and if the patient is more or less static, I might have a conversation with the patient and repeat it at, I would not do it at 4 weeks, probably 6 to 8 weeks is when I think that would be a good this thing. And if I'm seeing a fairly fair improvement in the parameters, also, systemic, because diabetes is different, DME is different from CSCR in that there's so much of influence of your systemic parameters, on that. If the patient's DME, it's something like 8, 9 or something, I might be a little more patient. There's a downtrend. But at the same time, let me, so this is it. So if it's less than 300, I'm more interested in being proactive, or around 300 to 400, more proactive with repetitive micropulse. Especially in our population, patients are more hesitant to get injections because everything is coming out of the pocket more or less. So that's also an important consideration in India and other Southeast Asia. I think that's important. And so there I'm a little more proactive. On the other hand, if there is an increasing trend, if the fluid is increasing, IRF or SRF is increasing beyond 400 microns, then I would be more proactive in suggesting anti-VEGF as an injection. I would probably do micropulse and anti-VEGF, or just anti-VEGF. So that's what I suggested in the last line. Yeah.
Thank you. Yeah.
You already raised the issue of systemic parameters.
Yes.
So what was that in these patients? And did you try to analyze whether
so
they were going to have a better control, metabolic control, better renal parameters by the time you start treating them?
Yeah.
We always advise metabolic control and check-up
sure.
of the renal conditions, and then trying to get their glomerular filtration rates better and all that.
Yeah.
Improved rather.
Yes, so these were not patients who are very severe, like on dialysis, or we excluded those patients with dialysis or very heavy, high blood pressure or very severe recent cardiac events. Sick patients, I'm talking of that little study of ours. So we had a large list of exclusion criteria also. Yeah, so we did. But otherwise, both the groups were comparable for all the other parameters, it's the same demographically. Yeah. Okay, thank you.